Welcome to DG Snack. This particular lecture will be covering cataracts, a brief overview on cataracts, the types of cataracts we see, and the procedures we do at our center. The contents of the talk is going to be an overview, etiology and risk factors of cataract, grading, symptoms and complications of cataract, the management consideration, the kind of surgeries that we do, and practically what you do when you list for a patient for cataract surgery and postoperative monitoring. Cataract refers to an opacification of the natural crystalline lens. It's among the commonest causes of, it is the commonest cause, in fact, of vision impairment worldwide. And, almost everyone gets in cataract as you grow older. For patients above 60, studies estimate prevalence to be in the range of 50% or so. In fact, according to WHO, so 38 million of people who are blind, half of them are blind due to cataract. So it's really a lot of reversible or treatable vision impairment. In Singapore, studies have shown that about 34% over the age of 40 have cataract that are visually significant, and 0.5% of them, in fact, are blind from cataract or poor vision because of cataract from the Tanjung Pagar eye study. So as you would have surmised, the commonest cataract that we see is a senile version, or the cataract due to old age. So, as for anything, you can dichotomize this an acquired causes of cataract and the congenital causes of cataract. Congenital cataracts, you see them, could be idiopathic, could be hereditary and developmental, could be due to metabolic syndromes, could be due to infective, look at the torture screen like toxoplasmosis, rubella, CMV, and could be due to tumor, like retinoblastoma, so it's like a secondary cataract, and sometimes rarely patients with uveitis in juvenile age group can also have cataracts. Acquired causes of cataract generally is due to age-related cataracts. That's the commonest one that we see. Sometimes due to trauma. Trauma can also result in cataracts. Or just associated with systemic disease like diabetes, myotonic dystrophica, uveitis, and drug use commonly. Steroids can result specifically in a posterior subcapsular sort of cataract. And sometimes traditional Chinese medicine do seem to contain some steroid component that can result in cataract. Other risk factors include UV radiation, history of exposure to UV radiation, diabetes, use of steroid medicines, previous eye injury, alcohol consumption. High myopes tend to have cataracts according to some studies. Of course, a family history. The commonest types of cataracts we see are the cortical, which is basically in a peripheral sort of thing, like a spoke-like appearance. You can see this patient has a bit of a C3, 4+ grade cortical cataract. Nucleus sclerotic cataract, you can see is like the dense nuclear core getting browner with time. So this is, you're getting yellower with time, and this is in fact a brunescent or grade 4+ cataract. And the posterior subcapsular cataract. This is typically, even a little bit of posterior subcapsular cataract can tend to be quite visually bothersome for the patient. So this is located right, as the name suggests, in the posterior subcapsular area. So the lens is held in the capsule, and this right in the center, in the posterior aspect of the lens, adjacent to the capsule. Rarely, patients may have posterior polar cataract, and that's a different sort of cataract which you need to be a bit more wary of, wherein capsule is involved. They may have a typical tadpole or wick sign, wherein the cataract sort of extends or is very adherent to the posterior capsule, and they may have an onion ring, and sometimes in some cases it's bilateral. So that is a different from posterior subcapsular per se, and that needs to be approached a bit more carefully. So there is the LOX3 classification system that they come up with, wherein they grade the opacification, the nucleus color and opalescence of the nuclear cataracts from 0 to 6, as you can see, and the cortical component from C1 to C5, and the posterior subcapsular from P1 to P5. So this is a standardized grading system as with regards to the opacity and the color of the cataract that helps you determine the severity of it, and also helps you manage the patient in conjunction with the patient's symptoms. And of course, there are many varieties of cataract. As you can see in the top left picture, this is a Morgangian, a very hyper mature cataract. Basically, the cataract is very mature, and the nucleus is basically within a mixture of cortical emulsified material within the capsule. So in this case, the bag tends to be very lax. It's quite difficult to do operation. There might be zonular weakness. So these patients tend to have they may have a small nucleus surrounded in the sea of white cortical material. This is hypermature cataracts. This is the posterior polar cataract. I was talking about the onion ring sign, and typically this involves the posterior capsule, and PCR rates have been in the rate of 20 to 50% in some studies for patients for whom we are doing cataract surgeries in posterior polar cases. Here you can see this polychromatic sort of Christmas tree cataract, typically associated with myotonic dystrophica, but it may be in other conditions as well. This is a snowflake or diabetic snowflake cataract, typically involving the cortical component, cortical aspect of the cataract. Although diabetics do also have posterior subcapsular and nucleus aortic cataracts. This cataract here is a sunflower cataract, which we typically see in Wilson's disease. Most patients, as you grow older, will get cataract, but many of them tend to be asymptomatic. Some patients complain of gradual onset blurring of vision. Some patients also complain of index myopia. Basically, they'll find that the degree is changing with time. They seem to get progressively worsening myopia, and this tends to happen in patients with a nucleus sclerotic cataract. And they will interestingly tell you that they can now read better. So patients who might have been ametropic may suddenly be able to, they will say that their friends need reading glasses, but they are able to see better for near, but for distance, their vision is a bit blurred. So this could be a function of the cataract causing a change in their refractive error, rather than your vision getting better. Some patients may complain of glare. This also typically happens in patients with cortical or posterior subcapsular cataract. And of course, reduced contrast. Any type of cataract can result in reduced contrast, typically the nucleus sclerotic. Cataracts can also cause complications. For example, cataract can result in secondary angle closure, glaucoma. For example, phacomorphic glaucoma is a glaucoma wherein there's intumescent cataract, a very thick cataract resulting in angle closure. Phacolytic and phacoanaphylactic cataracts are also cataracts. Phacolytic cataract, for example, occurs when it happens in a mature cataract where lens particles are able to diffuse through an abnormal capsule into the anterior chamber, inciting an inflammation, resulting in sort of a uveitic picture along with the cataract. The only treatment for this is to control inflammation and subsequently remove the cataract. Or phacoanaphylactic, wherein there's a breach in the capsule due to trauma or due to surgery, resulting in inflammation and sometimes glaucoma. You can see a very intumescent lens along with, and this is the ASOCT image showing quite a bit of a lens vault closing the angle anteriorly, resulting in a phacomorphic glaucoma. This patient here has phacoanaphylactic glaucoma, has had a surgery before, but the lens particles basically are floating in the anterior chamber, resulting in a uveitic picture and inflammatory glaucoma. This patient also has here the cataract inside the capsules not breached in this particular case, but this patient has a uveitic picture, so it's phacolytic glaucoma because of a mature cataract resulting in lens protein leaking across and causing a plugging of the meshwork, resulting in glaucoma and also causing inflammation in the process. How do you manage patients? Most patients tend to not have the complications. For example, they're typically coping well with their vision. It might have been a finding that we noticed on our examination. So if they're coping well with their vision, there are no other complications or complaints, we can just manage them conservatively. Patients complaining of index myopia, as a temporizing measure, we could just suggest glasses to change the degree. But however, if the degree is changing quite rapidly and the patient is quite uncomfortable with this new vision, or the patient complains of anisometropia or change in degree with regards to both eyes, and that's causing him significant problems in his day-to-day life or quality of life, then a cataract surgery might be mandated. So basically, when would you consider surgery? If the patient's quality of life is affected by his visual symptoms, if there are, of course, complications like lens-induced glaucoma, or if there's cataract obscuring the view of the fundus. For example, many patients with diabetic retinopathy or with diabetes require DR screening. So if the cataract is significant to obscure the view of the fundus for us to do proper screening, it might be a good idea to consider cataract surgery. Of course, congenital cataract is a whole new ball game, a different sort of ball game. You need to do early surgery. This needs to be managed well by the pediatric ophthalmologist to maximize the vision potential of the eye, and do early surgery to maximize to try to correct the error, the problem. Surgical options include phacoemulsification, which is the commonest performed surgery in the developed world for cataract. ECCE is basically extracapsular cataract extraction. wherein we manually extract cataract from the bag and we replace the lens through an incision that we create on the cornea, on the corneal limbus, and subsequently stitch up the incision. SICS is another type of surgery that they do in the developing world, which is like ECC in the sense that it's a mechanical extraction of the cataract by creating a scleral incision with a self-sealing tunnel, accessing the anterior chamber, and then removing the lens, removing the cataract from the capsule, and inserting a lens back into the capsule. And the only unique point about SICS as opposed to ECCE is that it does not require suturing because the wound created is a self-sealing wound through a scleral tunnel. Historical options include couching, which we don't practice at all, and ICCE, wherein the difference between ICCE and ECCE is that in ICCE, they remove the entire entire capsule lens complex. In ECCE, we just make a capsulotomy, an anterior capsulotomy, access the lens through that, remove it, and replace the lens within the intact capsule. Of course, this results in better visual recovery and prognosis because you can physiologically place the intraocular lens implant in its physiological location. So this is, as I was discussing, phacoemulsification typically uses a 1.8 to 2.75 mm corneal incision. And we inject a foldable intraocular lens implant into the bag subsequently after removing the cataract. And that enables quick visual rehabilitation for the patient. The good part about phacoemulsification is that the wound is very small. The capsule is intact. How we do this is by emulsifying the lens, by breaking the lens into multiple fragments and using a probe to be able to suck out or aspirate the lens fragments. For ECCE, we remove the entire nucleus in one block, basically by creating a capsulotomy through a corneal incision. And SICS I've discussed in my earlier slide. When you list a patient for cataract surgery, after discussing the patient, you need to be able to tell the patient that of course, life above eye, so he needs to be medically fit. So for example, if the patient's recently had an AMI or a stroke, you'd want the patient to be stable before you perform the surgery because any surgery can induce physiological stressors. Typically, we tend to wait for about 6 months prior to considering surgery for the eye. For patients with multiple medical comorbidities, you might want to check in with the cardiologist or the treating physician as to the medical fitness for operation. But remember that most of our operations are done under topical or regional anesthesia. So typically, it's generally quite a safe procedure. For patients with anticoagulants, which we can't stop, for example, warfarin, or patients on double antiplatelet agents for previous stroke or heart attack, it's best that we list under surgeons who can do the surgery under topical anesthesia so that they don't have to undergo a block, and block may have its associated complications such as bleeding. If vision is better than 6-12 and require requests for surgery due to symptoms or anisometropia, it's better that you refer the patient on for a consultant opinion in our center. If a patient's VA is poor with wide cataract or may have coexisting macular optic nerve comorbidities or even glaucoma, a guarded prognosis needs to be explained to the patient. Once again, this is best done in conjunction or collaboration with your consultant on board. So when you discuss with the patient, you need to discuss the benefits of cataract surgery, the risks and complications. Okay. So for benefits, you need to say to them the aim is to correct the vision to 6/9 or better, and this happens in more than 95% of our patients in our center. And we aim for better and brighter light and to improve the contrast sensitivity. This will also allow us to screen the fundus better for patients who have diabetes. By and large, it's a safe surgery, and with a greater than 95% success rate, there are some complications which we will discuss soon. An operation typically takes less than 20 minutes. It's a day surgery done under sedation with local anesthesia. There is a 2 to 3% chance of PCR, or posterior capsular rupture, which usually in good hands may be handled quite well with good visual rehabilitation in most circumstances. Rarely less than 1% chance of a nucleus drop when you have a PCR, wherein the nucleus drops to the back of the eye into the vitreous, and this might require the need of a vitreoretinal surgeon to come in to salvage the situation, remove the lens, and either implant a lens in the sulcus, depending on the integrity of the anterior axis, or sometimes the anterior chamber intraocular lens, or in some surgeons' hands, iris fix or scleral fix IOL at a second setting. The worst complication in cataract surgery would be endophthalmitis because of blindness, which can result in blindness. And this happens less than 1 in 1,000 cases. There's 1 in 1 million chance of sympathetic ophthalmia, which nowadays is managed better, which could have otherwise resulted in blindness for both eyes. Once again, this is a very rare complication. There's 1% chance of retinal tear, which may or may not be associated with a retinal detachment. So these are the more devastating possible complications of cataract surgery. Other risks include corneal decompensation, which may happen acutely or chronically with time, especially in patients with Fuchs endothelial corneal dystrophy. Sometimes cataract can result in decimate detachment, which is quite rare. And in that case, the patient might need to go in for second surgery to reattach the decimes. Common complications are that of wound leak, which may happen in a side pod wound, which usually resolves spontaneously. And sometimes patients may develop with time pseudophakic glaucoma. Refraction, we aim typically, most of our patients in the subsidized clinic, we give them a monofocal option. And typically we aim for good distance vision with the need for reading glasses post-operatively. If the patient wishes otherwise, or wants to consider multifocal or toric lenses, it is best that you refer them on to a consultant who does these procedures. And the patient would have to be listed under a private setting. There are special circumstances that you need to watch out for. These include white cataract, because you're unable to really see, have a good view of the fundus, the posterior pole. So you need to give a patient a guarded visual prognosis. A good idea would be to see whether the patient has any RAPD or not. If he has RAPD, of course, the visual prognosis is more grave. If there's no RAPD, you can also try to shine various colored lights, a green color light from the BIO, to see if the patient's able to recognize the various colored light. And that's a good sign. I mean, that shows that macula is working grossly. Sometimes some patients, some doctors, they try doing a PAM to see their maximum visual potential. White cataract also have a higher risk of PCR, zonulisis, and other complications, so you need to warn the patient of that. Other special circumstances include shallow anterior chamber, a previous angle closure attack, or PACS. So some of these patients may have already had a laser peripheral iridotomy, and they may actually have associated zonulisis, so you may need to be cautious when you proceed to list these patients for surgery. Of course, patients with dense cataract, these would require more phacoemulsification energy, and this can potentially lead to corneal decompensation. And sometimes some of these patients with dense cataract may also have associated loose zonule, so you need to be careful. Patients with high myopia, this is a unique situation where you need to discuss with the patient a few options. If the patient only has one eye has significant cataract and the other eye is quite asymptomatic, and he has high myopia in both eyes, typically if you do a unilateral cataract surgery, what will happen is we are aiming for monofocal correction of good distance vision. This will result in subsequent anisometropia after the surgery because you've corrected for the refractive error in one eye with the cataract surgery, but you left the other eye alone. So for example, the patient may have -6 for both eyes, and then now you're operated on the eye with a cataract, resulting in plano vision. Most adults are unable to tolerate this imbalance in refractive error, and there are ways to manage this. Either you can consider LASIK for the fellow eye, if the patient's young, or contact lens for the fellow eye, where there's significantly less effects from anisometropia. Other option is if the patient has some cataract in the left eye, in one eye, and you could consider sequential cataract surgery. This is also best discussed with the consultant in charge. The other option would be to aim for a monofocal intraocular lens of a similar refractive error to the fellow eye in very young patients, for example, who you don't think are going to benefit from sequential cataract surgery and who are not keen for LASIK or wearing a contact lens. This could be the other option, but we rarely use this. For patients with coexistent diabetic retinopathy, if they have moderate non-proliferative diabetic retinopathy, you might want to consider a light scatter PRP, or pan-retinal photocoagulation, prior to the operation, because there is a chance for the diabetic retinopathy to worsen following a cataract surgery. In some cases, there may also be worsening of clinically significant macular edema from diabetes following a cataract operation. So these you need to warn the patients of and monitor and manage accordingly. When you list for cataract surgery, typically you do biometry, which assesses the axial length, the keratometer, which is the corneal curvature, and will then give us formulae to calculate the intraocular lens power that we would need to put in the eye for the surgery. We do a B scan for patients with a white cataract to ensure that there's no gross retinal abnormality like a retinal detachment. For example, if a patient has white cataract and a B scan shows a retinal detachment, then of course we may not want to proceed with the cataract surgery because the prognosis is going to be very poor, and we might want to consult a VR surgeon for his opinion. A systemic workup typically involves taking a good history to see what the other medical comorbidities might be, doing a blood pressure check, a heart rate check, a urine dipstick, ECG, and hypocount. And if under GA, you might also want to consider doing a full blood count, urea, electrolyte, creatinine, and CXR, just X-ray, for patients that you need to do cataract surgery under GA under special circumstances. In our center, we ordered Tobrex or tobramycin 4 times a day to the eye, 1 to 2 days pre-operatively. Other options include Cravit or levofloxacin or moxifloxacin. Typically, in our post-op review, we see them 1 day after the operation, within 1 week after the operation, and 1 month after the operation. And what we look out for in the first day are the visual acuity, intraocular pressure. We look at the wounds, we look for any leaks, we look out for any AC activity, we look at the lens to ensure that it's in place and there's nothing untoward going on. Day 3 to 5, we are specifically looking out for complications that is sight-threatening, that is endophthalmitis. Endophthalmitis, most commonly acute postoperative endophthalmitis, typically occurs from day 3 to day 5 after the operation. So you need to watch out for any significant increase in inflammation or significant decrease in visual acuity in these patients. In 1 month, we check the patients for their visual acuity again, of course, intraocular pressure. We do a refraction to maximize their visual potential, and we do a dilated fundal examination to ensure everything's fine, to ensure they have no coexisting cystoid macular edema or Irvin-Guest syndrome. We review them further only if the patient requires further diabetic retinopathy screening or for management of other ocular conditions like glaucoma, or if you think that the patient might require subsequent cataract surgery in the other eye. So I'd like you all to read up more about the different types of cataract surgery that we do, watch some videos. We will load up some videos on our platform as to standard case of phacoemulsification surgery and a standard case of ECCE surgery for you to learn from. But yeah, so that should probably sum up the factors to consider when managing a patient with cataract. Thank you.